Hi, and welcome to Psychology 2. In part 2 of Psychological Disorders this week, we're going to look at a review of anxiety disorder, obsessive compulsion, and related disorders, somatoform disorders, dissociative disorders, and personality disorders. And again, a reminder, we're only doing a review of these topics, and they are much more complex than what we're going to really just cover here. Now, you may notice that the headings for the different psychological disorders are plural. This is because the headings are the different types or groups of disorders. Therefore, each have multiple disorders in each group. And again, I need to say, please, no self-diagnosing or diagnosing others. Let's begin with anxiety disorders. Anxiety disorders, if we're looking at a definition, if you will, let's start with anxiety. Anxiety is a generalized feeling of apprehension, fear, or tension. Anxiety is healthy and normal if it's a response to a real danger or a real threat and it prompts us to take action. Anxiety is unhealthy or abnormal if it's an inappropriate or excessive, if it does not fade soon after the danger has passed, or if it interferes with a person's social and work activities. Anxiety has psychological and physical features. The psychological features include worrying, fear of the worst things happening, fear of losing control, nervousness, and an inability to relax. The physical features include arousal of the sympathetic branch of the autonomic system. This includes trembling, sweating, pounding of your heart, elevated blood pressure, even including fainting. Now, our first anxiety disorder that we're going to look at are phobias. Phobias are persistent, irrational fears of an object, situation, or activity that a person feels compelled to avoid. Now, these can include snakes, thunder, blood, clowns. Now, the emphasis here is compelled to fear, if you will, or compelled to avoid. These aren't choices you're making, okay? So one of them, agoraphobia, is the fear of being in situations that escape is impossible, or help is not readily available in the case of incapacitating anxiety. You can also be experiencing something that's known as social anxiety disorder. It's again on the phobia range of things, fear of social situations in which one might be embarrassed or humiliated by appearing clumsy, foolish, or incompetent. Now, for most of us, these may not appear to be the kinds of things that you would attach a disorder label to. It's because you're not affected by these. For someone who is, it's not as easy. The third grouping is what we know as specific phobias, and it's a marked fear of specific objects or specific situations, and it's also a bit of a catch-all category for all phobias other than agoraphobias or social anxiety disorder. Now, these can include situations like, fear of being in an elevator or tight or enclosed spaces or airplanes. Could be a fear of natural environment, storms, water, heights, or a fear of animals, dogs, snakes, spiders, or the fear of blood, injection, or injury. This can be including seeing blood or receiving an injection. Now, when we go into abnormal psychology as a complete course in the fall, we go into all of these disorders, an explanation of what they look like, what causes them, and what are the treatments. Here we're going to do just quick reviews, okay? Okay, next we're going to look at panic disorder. And it can cause apprehension about reoccurrence and the consequences of future attacks. Now, this can lead sufferers to avoid situations that they associate with previous attacks. Sufferers tend to overuse the healthcare system and are at increased risk for alcohol and drug abuse. Both biological and genetic factors appear to affect panic disorder incidences. Now, the symptoms could include a shortness of breath, heavy sweating, tremors, pounding of heart, fear of suffocation, choking sensations, nausea, numbness, and a fear of going crazy or losing control. They don't sound pleasant, and from what I understand, they're not. Symptoms may last minutes, even hours, and seem to come from nowhere. Next is generalized anxiety disorder. This is about persistent anxiety that can't be attributed to a phobic object, situation, or activity. It seems to be free-floating. Generalized anxiety disorder is a condition of intense and unrealistic anxiety that lasts 6 months or more. That's not once in 6 months. That's pretty much daily for 6 months or more. This excessive anxiety may cause people to feel tense, edgy, tired, irritable, difficulty with concentrating and sleeping. They may have trembles, have palpitations, sweat, and experience dizziness, diarrhea, and frequent urination. Generalized anxiety disorder substantially reduces the quality of life for sufferers, which is about 9% of North Americans. So what explanations are there for anxiety disorders? A quick review will look at biological perspective, where anxiety tends to run in families. Twin studies show a higher concordance rate or correlational with identical twins among fraternal twins. The brain may be sensitive to not enough of GABA, a neurotransmitter that may help calm anxiety reactions. So having less available or less sensitive could explain a bit of that. Now, the psychological and social perspective on anxiety disorders, well, learning theorists suggest that phobias are conditioned fears. That is, we learn them, that we are acquiring them in childhood. Observational learning also plays a role. If I see somebody else be afraid of a dog, I might too be afraid of a dog. The biological imbalances could play a role. It may initially trigger events, with subsequent events being triggered by a combination of all three. Now, the next group we'll look at, and this is a tricky one, but we're going to look at the obsessive compulsive and related disorders. Now, we're going to look at obsessive compulsive disorder, hoarding disorder, and body dysmorphic disorder. Now, we'll start with obsessive compulsive disorder. Obsessive compulsive disorder is a disorder in which the person suffers from obsessions and/or compulsions. Obsessive compulsive disorder is characterized by, firstly, obsessions, and these are reoccurrent. They keep coming up. Anxiety-provoking, involuntary thoughts or images that seem irrational and disrupt daily life. These are not choices. The second is the compulsions. These are persistent, irresistible, ritualistic, and repetitive behaviors that reduce anxiety caused by the obsessive thought. Common compulsions include cleaning and checking behaviors, for example, including irresistible urges to check things like, is the door locked? Is the gas turned off? And not just doing it once, but doing it maybe 10, 15, 20 times. An important note here is that these are not choices. These are intrusions, and the person who's experiencing it is compelled to respond the way that they do. It's not a weakness of person. It is a condition. Hoarding disorder is characterized by excessive buying or collecting items with no removal of items, resulting in a severely cluttered living space. This is this is in fact a new condition that's been added to the DSM-5. Body dysmorphic disorder is characterized by a preoccupation with the imagined or exaggerated physical defect in one's appearance. Now, much time is spent looking at themselves in the mirror looking at themselves to desire to change something, a flaw. Maybe you think your nose is too big or your ears are too small, and so all your time is spent looking at that flaw, wondering how you can deal with it. They are preoccupied with the flaw and do whatever they can to alter or correct the flaw. So how do we explain OCD, obsessive compulsive disorder, and related disorders? Well, OCD has a strong genetic link, especially with twins. The neurological link, for example, the improper functioning of the frontal cortex, is paramount in this area, perhaps, they think. Hoarding has strong genetic causes. About 36% of variations of hoarding accounted for by genes tended to run in the family. Body dysmorphic disorder is related to abnormal functioning of the serotonin and dopamine and structural differences in the frontal cortex. They may go to extreme lengths to correct the problem. They believe that others see them as deformed. They may compulsively groom themselves. Now, the next group we're going to look at is the somatoform disorders. And this is a group of disorders. Somatoform disorders are characterized by physical problems such as paralysis, excessive pain, or a persistent belief that they have a serious disease, yet there's no evidence of physical abnormality that can be found. We'll start with conversion disorder. It's characterized by a major change or loss of physical functioning. Although there is no medical findings to explain the loss of functioning, the person's not faking, as he or she seems to be, converting a source of stress into a physical difficulty. Some people with this disorder show indifference to their symptoms. It's called la belle indifference. Hypochondrias is characterized by people insisting that they are suffering from a serious physical illness even though no medical evidence of the illness can be found. They become preoccupied with minor physical sensations and continue to believe that they are ill despite the reassurance from physicians that they are healthy. They in fact may even go from doctor to doctor seeking one who will find the real cause. Explaining somatoform disorders, well, we can use conversion disorder to suggest that some believe this disorder is a form of self-hypnosis or self-convincing a problem exists. Hypochondrias, people misinterpret the run-of-the-mill physical sensations. There is researched evidence that people who develop hypochondrias are particularly sensitive to body sensations and tend to ruminate about them. Now, our fourth group we're going to look at, and again I'm emphasizing this is just a review, is dissociative disorders. Dissociative disorders involve breaking in consciousness or memory or both. Under stress, a person loses the integration of consciousness, identity, and memories of important personal events. They provide a mental escape from intolerable circumstances for some people. Dissociative amnesia, in this particular condition, there's no physical cause such as a blow to the head that's present. Rather, a traumatic experience or a psychological blow, if you will, so to speak, or an unbearable anxiety situation causes the person to escape by forgetting. Cannot be attributed to biological problems. The amnesia may last for hours or years. Now, dissociative fugue is an extreme circumstance. Dissociative fugue, people forget their entire identity, travel away from home, may assume a new identity somewhere else as a reaction to some severe psychological stress. They do not report their past. If they do, they often invent memories. Now, a couple of components that are a part of these disorders is what's known as depersonalization, derealization disorder. And it's a disorder in which a person has experiences of unreality from oneself and surroundings. When your thoughts are not recognized as your own thoughts, they're just things that are creeping into your head from somewhere else. Or what you see outside yourself in the environment is not recognizable. You know, I'm in my basement, I look at a couch and a chair, and if I'm dealing with derealization, I don't recognize this as being a chair or a sofa. I don't know where they are, what they came from, who's put those there. Dissociative identity disorder, it's formally termed multiple personality disorder, and it's characterized by two or more identities or personalities, each with a distinct traits and memories occupying the same person. Most patients are female and victims of early, severe physical and/or sexual abuse. They typically complain of periods of lost time. There's a host personality, and the host is the one who is got the executive control of the body and the greatest percentage of the time. The alternative personalities or alter personalities may differ radically. These alternative personalities may have accents, different vocabularies, different tastes in clothes, hobbies, and be of a different gender or age even. Each identity may or may not be aware of the others. It's quite an amazing condition. Explaining dissociative disorders, well, the biopsychosocial factors may be involved here. It's combining biology, psychology, and sociology. Learning theorists suggest that people have learned not to think about bad memories or disturbing impulses in order to avoid feelings of anxiety, guilt, or shame. At a biological level, research with abused children have shown that trauma-related dissociation may have neurological basis. Child abuse may lead to permanent neurochemical and structural abnormalities in parts of the brain involved in cognition and memory. Okay, our last grouping is personality disorders. A personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectation of the individual's culture and is pervasive, inflexible, and has an onset in adolescence or early adulthood and is stable over time and tends to distress and leads to distress and impairment. Now, one example of these is what's known as borderline personality disorder, where the individual is unstable in mood, behavior, and self-image in the social relationships, and they have an intense fear of abandonment, exhibit impulsive and reckless behavior and inappropriate anger, and sometimes can make suicidal gestures and perform self-mutilation acts. Another in this group under personality was the antisocial personality disorder, and is characterized by persistently violating the rights of others and being in conflict with the law. Individuals often show superficial charm, but they lack guilt or anxiety about their misdeeds. They fail to learn from punishment. They fail to learn meaningful bonds with other people. Women are more likely than men to have anxiety and depressive disorder. Men are more likely to have antisocial personality disorder, with 2 to 3% as the rate in the Canadian population. Avoidant personality disorder is where individuals are generally unwilling to enter into a relationship without some assurance of acceptance, because they fear rejection and criticism. Now, unlike schizoid personality disorder, they don't have some feelings of warmth toward other people. They do have some feelings of warmth toward other people, The next one is called narcissistic personality disorder. And it's a personality disorder characterized by efforts to build up one's own feelings of self-worth through attention-seeking and approval of others. It sounds like some people I know. Obsessive compulsive personality disorder. Now, this is not to be confused with obsessive compulsive disorder. Obsessive compulsive personality disorder is characterized by rigid perfectionism and inflexibility in standards, resulting in poor close relationships. So it's not nearly about obsessive and compulsiveness as much as it is about having everything be precisely the way that you want them. And you're not tolerating differences, and as a result, you chances are don't form very many close relationships. The next will be schizotypical or schizotypal personality disorder, and it's a personality disorder characterized by an impairment in social and close relationships. Peculiarities of thought, perception, and behavior exist. So if we're going to explain personality disorders, we can look again at the biological. Biological factors include heritability, seems to influence personality disorders. Possibly prefrontal cortex of the brain connected with emotional responses in antisocial personality disorder. Some of the psychological factors, we look to again the learning theorists, where they suggest that childhood experiences could contribute to maladaptive ways of relating to others in adulthood. The cognitive psychologists have found that antisocial adolescents encode social information in ways that bolster their misdeeds. Sociocultural factors, well, we live in a fragmented and alienating time that tends to create problems in forming stable identities and stable relationships, which may contribute to borderline personality disorder. Now, I'm aware that this has been a quick overview on a fairly difficult topic, but it's really just to give you an idea. One, we've only touched basically the tip of the iceberg on psychological disorders with this review, and that's partly what Psychology 1 and Psychology 2 are to be. It's an overview of content where some of the chapters are themselves specific and unique fields of study, which have easily 14 weeks, like in what we're doing now, of content. So it feels overwhelming, but we won't be doing and diving deep, so the content might be enough and more light. So I hope this has been helpful. Good luck, everybody. In the next 2 weeks following, we're going to look at therapies. All right, so bye for now.